Right responses of OSMCon 2014 are NECC and Marico. Our next delegate, G. Manvitha and B. Alekhya.
A very good morning to one and all. Myself, Alekhya, and my colleague Manvitha are here to present a case on functional dysphonia. First of all, functional dysphonia is a condition wherein there is poor voice quality without any obvious anatomical or neurological abnormality in the larynx. Coming to the case, a female patient of age 16 years, studying in 9th standard, a resident of Khammam district, came to us with the chief complaints of loss of voice and inability to speak aloud since 9 months. The patient was apparently asymptomatic 9 months back, after which she developed loss of voice and inability to speak aloud, that is sudden in onset, continuous and non-progressive. She hails from a local tribal group and she was staying in a government hostel with her seniors as her roommates. As per her history, she was being ragged by her seniors that there were ghosts in their hostel and she was controlled by the ghosts. Because of her tribal background and a strong belief on superstitions, she started believing that there was a ghost inside her throat. Because of this fear, she gradually lost her ability to speak aloud and developed an inferiority complex. There was no history of trauma, and we ruled out history of fever, cough, blood-stained sputum, difficulty in breathing, aspiration, shortness of breath, chest pain, and difficulty in swallowing. Past history: in her 2nd standard, she had an episode of seizure followed by coma for a period of 2 days following a dog bite. There was no history of hypertension, diabetes mellitus, tuberculosis, or epilepsy. There was also no history of any previous surgeries. Her family history stated that she is the second issue of non-consanguineous parents having an elder brother. Her developmental milestones were reported to be normal. Her father expired in her early childhood, which had a great impact on her behavior. She did not have a good bonding with her brother, who used to be very rash with her and their mother, that also affected her mental development. Personal history: her appetite was normal, diet mixed, bowel and bladder habits were normal, sleep was normal, and she did not have any addictions. She did not attain menarche, and there was no known drug allergies. General examination: the patient was conscious, coherent and cooperative. The patient was weak, poorly nourished and moderately built. Pallor was present. Icterus, clubbing, cyanosis, koilonychia, lymphadenopathy and edema were absent. Vitals: pulse rate was 82 beats per minute with normal rhythm. Condition: nature and volume of the vessels. Blood pressure 120 by 80 mm of mercury measured in right hand in sitting position using a sphygmomanometer. She was afebrile and her respiratory rate was 20 cycles per minute. Systemic examination: cardiovascular system S1 and S2 were heard. Respiratory system: bilateral vesicular breath sounds were heard. Gastrointestinal system revealed no abnormalities and her central nervous system was found to be intact. Coming to the local examination: throat and oral cavity, lips, teeth, tongue and retromolar trigone were normal. Anterior and posterior pillars were normal and posterior pharyngeal wall was mildly granular. On neck examination, laryngeal crepitus was present and jugulodigastric lymph nodes were not palpable. Indirect laryngoscopy revealed that bilateral vocal cords were normal and mobile and bilateral arytenoids were normal. Video laryngoscopy revealed that there was a phonatory gap seen and redundant mucosa was seen. On laryngoscopy and bronchoscopy, cough reflex was seen and both vocal cords adducted fully on coughing. Coming to the investigations which supported our diagnosis: hemogram or complete blood picture was normal, renal function tests were normal, and HIV and HBS AG tests were negative. Chest X-ray, PA view, X-ray of PNS, neck lateral view and skull lateral view detected no abnormalities. Ultrasound scan of neck, abdomen and pelvis revealed no abnormalities. ECG was normal and serum electrolytes: sodium 142 millimoles per liter and potassium was 4.3 millimoles per liter. Therefore, based on the history and the examinations done and the investigations, we could diagnose the condition as psychogenic functional dysphonia. Other differential diagnoses which may present with the similar clinical features include chronic laryngitis, vocal cord polyps, ring case edema, vocal nodules, dysphonia plica ventricularis, laryngeal trauma which may be iatrogenic, accidental, suicidal or homicidal, and vocal cord palsy. The treatment which was given to the patient included psychological counseling because of her instinct of ghosts, and cognitive therapy, adduction techniques to bring the vocal cords together to reduce the phonatory gap, behavior modification therapy such as relaxation therapy, supportive pharmacotherapy that included capsule Otrin. Its composition is folic acid and iron fumarate, and warm saline gargles, and also hypnotic therapy under general anesthesia was given. After this course of therapy, the patient started speaking successfully. Her prognosis was good, and follow-up period was for 7 days. In this course, she was taking regular counseling sessions by the psychologist, supportive pharmacotherapy was continued, and physical reassurance was given by the ENT surgeon. The general condition of the patient gradually improved and her vitals were stabilized. She was also provided with health education regarding her nutritional diet. She was advised to continue the above medication. References. This is the patient case sheet. Thank you.
Lot of psychological trauma, the background was that.
Yes, sir.
And why did you subject her to general anesthesia?
Sir, because she couldn't, she became very infurious, sir. I mean, when our ENT doctor, he was trying to counsel her, and he was trying to tell her that there were no ghosts inside her. She couldn't she couldn't control that, and she was...
Then she should have been subject to psychological counseling, because general anesthesia is a risk. And you can't... Is there any procedure described anywhere, surgically, otherwise, for functional dysphonia?
Yes.
You can't subject the patient to the risk of general anesthesia, and you are telling that you have removed the ghost.
Yes, sir. She was actually told that the ghost is being taken away from her throat, because...
That's what I am saying. Can an allopathic surgeon practice removal of ghosts under general anesthesia? That is the ethical and legal question. You are on record saying you have given general anesthesia and assuring the patient that you have removed the ghost, instead of making her get convinced by a psychologist, clinical psychologist or psychiatrist, that there are no ghosts. The ghost is going to come back once she goes back to her hostel. General anesthesia is not going to remove ghost. So that's a wrong protocol. Secondly, with that much of psychological trauma, and that must have been only one manifestation of all the psychological trauma. This is not going to be the lonely manifestation. There are going to be many things. Maybe she has to be shifted from that hostel, maybe she has to be given some counseling, but that procedure is going to be dangerous in more than one way. Number one, ethical question. Number two, like allopathy people doing it. Number two, the legal question. Number three, the recurrence. Number four, patient may start demanding general anesthesia each time she is going into such sort of functional dysphonia.
Did you follow this case, or who has treated actually, whether it is ENT surgeon or a psychologist?
Both of them, sir. Actually, she was given a continuous psychological counseling, sir.
Yeah,
and she presented with
yeah, what I feel is she must not have been taken to the ENT theatre where they must have given general anesthesia. That must be some hypnotic agent which has been given by the psychologist with suggestion.
Yes.
Isn't it? Are you sure about it? I'm not sure.
It was not a hypnotist. Your surgeon alone has given that, if I am right. Okay. Suppose it were to be hypnotherapy, which drugs are to be given?
Phenobarbital. And
you have entered into the quicksand of hypnotherapy. What I am saying is, any such sort of practice is going to set a very bad precedence for practice, even a clinical practice or clinical treatment of diseases.
yes.
Okay, at least where maybe you achieved some result, we are not impressed. Okay, that is not the protocol.
You have seen the literature. What is the option left to you if you have diagnosed it as a functional dysphonia? One is the psychological counseling. If she is not responding to the counseling, next, what is the option left to you?
Hypnotic therapy, hypnosis, relax.
Is there any pharmacological or any other way of treatment? Is there any role of electroconvulsive therapy?
So,
I think what they have given is maybe only electroconvulsive therapy. It is not a general anesthesia or nothing. You just find out with the psychiatrist. But usually what I know is in case of functional dysphagia or functional dysphonia and all these patients, with electroconvulsive therapy, they will respond. You just see the literature.
Okay, we'll go to the next question.
It's a very good presentation anyway. I know the treatment part, you are not responsible, but I mentioned all these so that all the students would know certain aspects of it. Okay? We cannot